Now I'm going to take you through hip range of motion. And again, what you're looking at is initially active range of motion. Then you can always ask the patient to go through actively. I'm going to show you the passive range of motion, and then you can apply overpressure at the end of each of these to test non-contractile structures. So for passive range of motion, for hip flexion, you're just simply going to bring the hip into end range flexion. If the patient has knee issues, I'll sometimes support their leg up here to keep the knee at a relatively mid-range area, and I come in and then I can apply a little bit of overpressure there. For hip extension, what I typically do in this position is I'll have the patient hug their opposite knee into their chest, and then I measure how flat is the opposite leg to the table, and it should be full extension, it should be flat on the table there. So that would be considered normal. Oftentimes, if they're tight through the hip flexors, you'll see the knee pop up just like that. Go ahead and slow down. For internal and external rotation, you bring the patient up into this 90-90 position, and you're going to bring the patient into internal rotation. Again, you want to think about what direction the femur is moving, not necessarily where the foot is going. And then external rotation here. You want to be careful to watch the pelvis, because what we don't want to do is bring in a little bit of hip hike and movement in through the lumbar spine. So you're really just going until you feel the hip itself stop moving. Same is true for AB and adduction. You want to make sure that the hip joint is what's moving, so your hip joint is down here at the head of the femur. So as you come into abduction, you're going to bring the leg out until you feel the resistance, and you're not going to go further into lateral bending of the lumbar spine or a lifting through the hip bone. For adduction, you can bring the opposite leg out into abduction, and again, you're watching for any dropping down of this pelvis on the same side. You can put a hand on the ASIS, and if that starts to drop down, you know you've gone too far. Another way you can check for hip extension, I'm going to have you flip over into your stomach for me, is to have the patient lie on their stomach. Then you can come through here, support the knee, stabilize the hip, and then passively bring them up into extension.